MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming. Welcome to MedBix Webcast. This is Ramana Hanamaraju. I'm the host. No, I'm not Albert Einstein, but I'm pretty good. It's a joke. You know, we have a much more smarter people than me attending today, talking. They're going to talk. The reason I started this channel to advocate physician advocacy, and then I want the physicians to be in the frontline innovators. For that, you need to you need to have some background in different fields, exposure at least, mathematics, physics, art, philosophy, and technology. All of them, you need to have some exposure to that, and it gives you different ideas and then different thinking, the way they look at the systems. So we have a wonderful guest, Dr. Suresh Mukherji, joining from Indianapolis, is a radiologist and radiation oncologist. He's a professor of radiation and radiologist, professor of radiology and radiation oncology, and he teaches at he was at the University of Illinois and the Robert Wood Johnson Medical School. So let me welcome Dr. Suresh Mukherji. Dr. Mukherji, welcome to the MedBix Webcast.
Hey, Rama, how are you doing? It's great to be back again, and great to see you, and great to be in front of your audience again.
Thank you so much, sir. I wanted to ask you, give me some background of yours, if you don't mind, where you started your career. And
Sure. So I grew up in Kentucky, in Louisville, Kentucky. I went to Duke undergraduate, graduated in 1983, in the last century. So I've been around for a while. I've seen a lot of changes. Did my medical school at Georgetown University School of Medicine. I did my residency at Harvard at the Brigham and Women's Hospital, and did my fellowship at the University of University of Florida in Gainesville. And then that finished up my fellowship in 1994. Then was a faculty member at University of North Carolina from 1994 until 2001. And then we moved to Ann Arbor, Michigan, and I was division director of neuroradiology from 2001 until about 2013. And then I became chair of radiology at Michigan State University, along with chief medical officer. And I did that until about 2019. And then we moved to Indianapolis, and I live in Indianapolis right now. I'm a professor of radiology at the University of Illinois, professor of radiation oncology at the Robert Wood Johnson School of Medicine, and a faculty member of ENT at Michigan State University. So that was my academic background. I've had a little bit of success publishing, published 15 books and about 400 papers, and I still travel a lot. I'm sort of right in the middle of my travels right now. I'm back in Indianapolis now. I just came back from 2 trips from India and about to head to another series of international trips beginning in about 3 weeks.
You have very distinguished credentials, no question. My daughter asked me, I need to ask some personal questions because who inspired you to be in radiology, or a particular person, or it's a particular incident caused you to be in radiology and radiation oncology?
Well, I think the motivation really came from my parents because, obviously I think we all get our motivation from our parents. My father instilled to me that, no matter what life throws at you, if you work hard, I think good things will always come. So I think what motivates me on a daily basis when I get out of bed, even though I've got 2 grown-up kids that are doing very well, I think I personally don't think I need to prove anything, but what keeps me motivated now is just, passion for what I do. And if you get up every day and work hard, good things will come. From a radiologist standpoint, I had a wonderful mentor in medical school, and just by chance, I happened to meet him at a actually at a party when I was in medical school. And he and I struck up a conversation, and I told him I was interested in research at the time. And that night he offered me a fellowship, and the next day I got the fellowship, believe it or not. And that really was the origin of my passion in radiology. And so that's how I became a radiology. That was back in 1980, I think it was 1986. And then I decided to become a radiologist the next day after I got my fellowship.
You're wearing two hats, a radiologist as a radiation oncologist. So tell me, what are the advances going on in the? Please tell us what do you think of the advances in radiology side and radiation oncology side? What do you think you saw the advances?
Well, my formal training is in radiology, so my radiation oncology component is mostly for education and teaching. So I can't honestly say that I know all the advances in radiation oncology, but basically there is so much of an overlap in radiology and radiation oncology. So I think the biggest advances actually in both fields, um, in a way because of my bias, because I spend a lot of time treating and interacting with patients with head and neck cancer, is that cancer is changing. One of my roles is that if you have a cancer, one of the first things that you do is that you want to determine what your prognosis is going to be, and that's based on staging of your tumor. And so the main American staging of how we stage tumors, any type of tumors in the United States, is based on the AJCC, which is the American Joint Commission on Cancer. So that is a group of individuals that gets together on a periodical basis and actually defines what the stages of cancer will be. And so I've been on that committee for the last 20, 25 years. So I've sort of seen cancer staging evolve over the last 20, 25 years. And what has become apparent to me is that the way you stage cancers is incredibly dependent on imaging. So if you have a cancer and you do a CT or an MRI scan, the information that we see on that directly affects how the patient is staged, which is eventually linked to the prognosis. And that's very important information. But that is really static information. Basically, we take our pictures, we assess the spread of the tumor, and then we can demonstrate what the stage is, which affects prognosis. But moving forward, what we are really focused on in radiology is to be more focused on metabolic and physiological imaging. So right now we have the capability to measure not only the pure anatomic standpoint that we learn in medical school, but things such as what is the molecular motion within these various tumors? What is the biology of these tumors? How do these tumors get their blood supply? And then as these tumors are treated, not only can we look and see whether they shrink, but we have the ability to look at changes in physiological function of these tumors. So if we do our new advanced techniques, we can see whether or not the blood flow has changed. We can see whether or not the actual molecular structures of these tumors are changing. And that's a big change compared to 10 years ago. So,
Is there a correlation of
yes.
data coming from pathology side? Still, the imaging is a central focus of the detection and the treatment of the cancer.
Yeah, and you ask a great question, because I think, when we look at our images, sometimes it's hard for people outside of radiology to believe what we're seeing. And the question is it actually correlated with pathology? And the answer is yes. But what's even more important is that now, over a 10-year period, the radiation oncologists are now starting to integrate these into how they're treating tumors. So in general, with radiation oncology, you would treat the tumor and then you would see whether it responded or not. But now we have new techniques in radiation oncology that are adjusting the treatment based on biological responses of the tumor. And a lot of that biological responses of the tumor is based on the physiological information that we can provide on imaging. So I think that's one of the big frontiers that we will see more integration and emphasis and innovations for not only the diagnosis of cancer, but also the treatment and monitoring treatment response.
You think we are handling now the young people, according to CNN, the young people are getting affected by these cancers now. Do you think these we are reaching, we're understanding the cancer much better than before, and then we are trying to get the control of this cancer? You think what is the state of the affairs of the cancer, diagnosis and treatment both?
Yeah, I think it's a great question. I think from a pure cancer standpoint, we 20, 25 years ago when we started, we thought all cancers were the same. So we would give the cancer a name. We would call it, you can call it lymphoma, you can call it a sarcoma, you can call it a carcinoma. But what's happened over the last 20 to 25 years is that we realize that not all cancers are the same. And there's an important concept regarding the concept of heterogeneity, where we think that not all cancers are alike. And cancers are comprised of different cells. And when the pathologist starts to look at a cancer, or they start to grade the cancer, what they're looking for is the most ominous part of the cancer. So cancers are very heterogeneous, and they're heterogeneous both at the cellular level, but now we're starting to understand at the molecular level and the genomic level. And what we're finding out is that the molecular level and the genomic level, there's even more heterogeneity than we anticipated. So a lot of these new treatments are targeted at genomics, they're targeted at cell surface receptors. And one would think that if there is a specific target for a specific receptor, well, all those cancer cells would be cured or destroyed. But that's not the case, is because within each cancer cell, because of that heterogeneity, not all the treatments are as effective as we would have hoped for. So moving forward, I think one of the things that we have to understand is that, yes, we have made innovations. We are understanding things at the genomic level, and we're understanding things at the enzymatic level, and at the physiological level. But again, that whole concept of these tumors being heterogeneous continues to persist. So we are making strides. If you could ask me specifically, there's some cancers that I was worried about when I grew up. I thought if I had Hodgkin's disease, I would definitely die. When I was back in the last century, when I was your age, Ramu. But back when I was your age, Ramu, back many, many
Of
years
course, I
ago, if
agree.
I had Hodgkin's disease, I knew I was going to die. But that's not the case. It's a very treatable disease, and there are numerous tumors and cancers right now that are treatable, which are incredible strides. But when we still look at some of these cancers that we're struggling with, the reason why we haven't been as successful is that they're much more heterogeneous in their nature. So therefore, one treatment is not completely curable.
So the data is coming from different sites, like artificial intelligence data or molecular side, cellular side. The data is coming. Is it artificial intelligence is helping you to manage that data and they're giving you a better picture, better advances in the care and treatment and the diagnosis wise? Is it giving you tools for you? That's artificial intelligence and machine learning.
Yeah, I think I would say that artificial intelligence hasn't reached its full potential yet. I think if you look at the actual treatment of cancer, because there's so much variability between doctors and institutions and treatments and electronic health records, I don't think we've necessarily reached our full potential. So I think when we look at artificial intelligence and we look at cancer care, there's so many factors that come into play. There are things like, what tumor do we have? What's the grade of the tumor? What's the molecular profile of the tumor? What's the age of the patient? Does the patient have any immune deficiencies or areas that are immune suppressed that can somehow affect the overall treatment? That has always been some of the promise of artificial intelligence. If we can take all this information using neural networks, well, maybe we can identify what the optimal treatment would be. But from a pure cancer prognostic standpoint, we haven't reached that. Go ahead. I think with me being a radiologist, that's a whole nother conversation that we can delve into if you wish regarding the field of artificial intelligence and radiology.
Yeah, yeah, absolutely. So that I am, I'm as a physicist, I'm going to present you something. We all believe in the unified field theory. Albert Einstein said that unified field theory, there must be a genesis for everything, one place, one cause. That's I'm going to present that loss, and then I'm going to come back and talk with you about the Silicon Valley, how they are approaching the radiology field of radiology, and how the field of the artificial intelligence. You can give us a little bit more explanation. I'm going to present this topic on the unified field theory of the cancers. Probably, it may not agree, but let me both we can watch together, and then I will. Just let me show. Yeah, that's good. So this is the I'm going to talk about the loss of symmetry. Very interesting. That is Dr. Suresh Mukherjee is talking about the unified field theory. As you all know, the Leonardo da Vinci gave the illustrated the picture of the symmetry in his famous art. That is the bilateral symmetry. This left side is supposed to be the right side, or both are equal, almost the mirror image of each other. That was he's demonstrating. Leonardo da Vinci, the famous Italian painter, was demonstrating that. That's a famous painter that you see on most of the doctors' offices and hospitals. And then also, if you see the heart is the outside structure is a bilateral. If you take the left side of it, if you draw a map in the line between them, is actually it is a bilateral. The left side is a mirror image of the right side. Same with the lungs. So symmetry is in the nature, is in our bodies, is constructed through symmetries. But loss of symmetry, or both biological and medical, you will see the butterfly in the both sides, left side and right side. There is a opposite mirror symmetry that you see on the left side is almost equal to the right side. That is in the lungs also. In the medical imaging, Dr. Mukherjee is a radiologist. They compare sometimes the lungs on the both sides and then see that is any abnormalities with the comparison, because that we have the bilateral symmetry on the lungs. We have two symmetries. So it's a biological and medical side. You see a phenomenon of loss of symmetry, and it's a both structural. And then you saw the picture of this one that you saw, that functional. Functional. I'm going to talk about loss of symmetry, about the how do you perform in the field. For example, the irregular asymmetric phenomena. If they don't have the right postures of in the football, for example, they are prone to injury. If they are not symmetrically operating, they are more prone to injury and concussions. So that is a loss of symmetry play a very important role, both structural and functional side. So this is the beauty of symmetry. You always see there's a beautiful flowers, the radial symmetry they call, and you see the symmetry is always there. And we consider symmetrical things are more beautiful. In fact, this is the famous the Hollywood and Bollywood actors is a Marilyn Monroe, and then Denzel Washington, and a Bollywood actress Aishwarya Roy. We consider them as the in general, that in the media they consider them as the most beautiful people, because when one of the things they do is, when you have a bilateral symmetry, when you split that, when you draw a mark in between the eyebrows, the left side is mirror image of the right side. More they are similar to that, we consider they're more beautiful. So that's bilateral symmetry. So we consider beauty, we see the bilateral symmetry, more bilateral symmetry you see, we consider them as the more beautiful. It is a research done actually. In fact, the sex of a woman, that they say that woman enjoy more sex with a man with a bilateral symmetry, with a face on the sides of the both. That's they did the research, in fact, particularly for women. And then even honeybees, they go to the radial symmetry. They prefer flowers more beautiful, not just honey alone. They prefer the flowers who are mostly radial symmetry more there. So that's even the honeybees prefer the beauty in the radial symmetry. They look for symmetry in that sense. But the fear of asymmetry, if there is not a symmetrical, you see a lot of pictures in the villain picture, or the always bad characters are always their bilateral symmetry is missing. One side is not the reflection of the other side. They have patch, they have some deformed eyes, deformed problem. There's a Frankenstein, and all these things you see in the movies to show that the asymmetry, a fear of asymmetry we have. That is they're exploiting our fear of asymmetry. So we think symmetry is a safe. That's one of the things. In fact, that is a plays a role in the OCD, obsessive compulsory disorder. The fear of asymmetry is, it may not be psychological disorder. It may be mostly the research is suggesting us it is the evolutionary genetic disorder. It could be fear of asymmetry. It came from the savannas of Africa. That fear, that asymmetric fear, came from, for humans, maybe coming from the beginning of human civilization. So asymmetry, obsessive compulsory disorder definitely is one of the things. But let us put aside the symmetry part. Let us talk about Albert Einstein. I will come back to the symmetry a little bit in a second. Albert Einstein got a big problem. Albert Einstein got a problem. Nobody can answer that question that easy. So the law of conservation of energy is the first law of conservation of energy is neither created nor destroyed. That's the laws of physics. That's the first law that they are taught. They taught us that law of conservation of energy is the holy grail of the laws of physics. But there is a problem. When Einstein was designing the laws for the universe, and he was describing the universal laws of the universe, the expanding universe does not contain the conservation of energy. The expanding universe is not holding the truth, the law of conservation of energy. That's a big problem for Einstein. And he was lost in the, there is no man can match the Albert Einstein. Only woman came to rescue. There is certainly a woman. Her name is Emmy Noether. She's a mathematician from Germany. She came to rescue for Albert Einstein, believe me or not. And I'm going to play a video of what is symmetries are. So just a minute, and I'm going to play that video, quick video.
Look into a mirror, wave your hand, and your reflection will wave back at you. In everyday life, it's easy to take the effect of symmetry for granted. But symmetry is vital to understanding and predicting how our universe works. This relationship between symmetry and the mechanics of the universe was something Emmy Noether proved in 1915 with her remarkable theorem, linking maths and physics in one harmonious statement. Wherever there is a symmetry of nature, there's a corresponding conservation law. So what exactly do we mean by symmetry in physics? Well, it can be described as a transformation that leaves a system fundamentally unchanged after the transformation has been performed. It's a change that makes no change. Take, for example, spatial translation. If we have a system and move it to a different point in space, that system would continue to work in the same way, provided all of the relevant conditions of that system were moved along with it. In other words, the laws of physics are not affected by translation in space. And similarly, with time translation, a system can be shifted at any point in time, and its physics would remain unchanged too. Even the most fundamental laws of physics are themselves symmetrical. They remain the same wherever or whenever you are in the universe. The symmetry of time translation confirms to us that energy cannot be created or destroyed.
Sorry about that. So yeah, sorry about that. Still, thank you for that, Dr. Mukherjee. Yes, so is a translation time symmetry. Suppose if you throw a ball, it is coming today. Yesterday, if you throw a ball to the sky, it will come back. If you throw tomorrow, today, it will come back. It will throw the ball tomorrow, it will come back. That time symmetry depends on it. Is the laws of physics does not depend on the time. Is a time symmetry is the actually that translates into the conservation of energy. That's very strange, but he does. It does the that becomes a law of conservation of energy. If you take the snowflake, for example, if you move around any which direction which you turn around, it looks exactly the same. It doesn't make any difference. That is called translation energy. That is a conservation of angular momentum. That is, sorry, rotational energy. That is the angular momentum it does. If you, for example, translation energy is when you're driving in a car, it is not flying off to the sky, because the reason is you think it is so simple and silly, but these are the laws of nature that is keeping the car going in the right direction on the ground. These are the laws of symmetry are governing the entire universe. They are the more fundamental. That the Einstein realized it. Those are the most fundamental laws. He called it a genius, in fact. So the symmetry, for example, structural symmetry in the breast cancer, in the detection and the reconstruction, Dr. Mukherji does all the time, so those kind of radiology images of the detection of the structural symmetry of the both breasts, you can compare and construct. And the reconstruction, for example, if they want to do the reconstruction plastic surgery, that they need to watch the both the symmetrical structure of the both breasts. That's orthopedics, for example, same thing. In surgery, they both legs are symmetrically should be there. Prosthetics construct. If you are designing a prosthetics, you must know the symmetry of the legs and all those things. So symmetry plays a very important, structural symmetry plays a very important role. In the functional symmetry side, the sports medicine, for example, is a very important role. So injury prevention, balance, and they teach you how to balance. If you do asymmetric people or asymmetric motion, it creates a more danger to the asymmetric motions, creates the injury and more prone to the injury and the less performance. So to improve performance, you need to understand the symmetrical movements. In the drug discovery, protein folding is important. How it folds and what it folds, because molecular integrity, when you change the side of if you turn around the molecule, it may act different. The properties may change. So this, you have to understand the functional symmetry is very critical to understand those kind of things. So symmetry is a fundamental to the understanding of the process. The fractal symmetry, for example, the people who goes through the LSD, psilocybin, all this, the psychedelic drugs, they understand that they see a kind of a fractal geometry, a fractal geometry they see. That's called fractal symmetries. They see. So we are actually on the Brain Cafe, I'm doing it, is to address that fractal symmetry, that we can simulate that fractal symmetries in the virtual reality, and can what the psilocybin is doing to treat the depression and calm the nerves, mental relaxation. We can do that through the virtual reality now. There's a lot of research coming in that direction. So fractal symmetries are fractal analysis of the heart rate variability. I used to sell autonomic dysfunction test. That's where heart rate variability, you can tell from the heart rate variability, you can tell the nervous system. Central nervous system is very correlated with the central nervous system, heart rate variability. The breast cancer, I told you, complexity and irregularity of the breast tissue in mammograms. So the Dr. Suresh Mukherji reads all day, that's kind of things. So, but is doing radiation oncology also. But nature's wonder, human body is a really universal laws govern the human body. It is not coming from some rare, it did not come from anywhere. It came directly from the universal laws. Those are the symmetry laws. So the Emmy Nader, she spent in different countries. So she went to Russia for a while, and then eventually she came to United States after the Second World War, during the Second World War time. Before 1935, the Hitler is making noises. Then she moved to United States, and then she was lecturing in the Princeton on the request of Albert Einstein, but she moved to as a faculty member at the Bryn Mawr College in Pennsylvania, and then right after 2 years after that, she got inflicted with ovarian cancer and she died. And she's a remarkable woman, produced a tremendous, underrated, underrepresented in the history. is the MA Nather. In physics, we consider her as the most one of the genius, equal to almost Albert Einstein. So let me, so that is the story of the MA Nather and the symmetries loss. Let me bring Dr. To this one. And yes, that is the loss of symmetry. We all believe, physicists believe, there is a something universal laws govern these things. The cancer, we are not, we are having a problem with the doctors that cancer is such a heterogeneous disease, that we are struggling to understand that is still from physics point of view. And physics is also did not solve their own problem, unification problem. Electromagnetic, all the forces are not unified. So we are struggling with all those things. We don't know yet what's going on with it. So cancer, at least you are all doing some advances. Tell me what advances are coming to cancer detection. And the Silicon Valley is saying that we can solve all these problems. What do you say to Silicon Valley and the people like physics people? You have some solution for that, Dr. Mukherjee?
Well, I assume you're referring to artificial intelligence.
Correct.
And so there's a lot of enthusiasm regarding artificial intelligence in all of radiology and all of medical imaging, to the extent that about 7 years ago, there was a sense and comments made by very well-respected people, including President Obama at the time, that you don't need radiologists, that the field of radiology would become obsolete. And that hasn't nearly been the case. In fact, right now, I just looked at the data. If you're in the medical field, after you finish medical school, you do a residency, and this is the week of the match. We call it a match because this is where prospective medical students determine whether or not they're going to be accepted into a subspecialty training program. So we have different subspecialty programs like radiology, orthopedic surgery, pediatrics, medicine, neurosurgery. This is the week we all find out whether a medical student is going to match into these fields. And it turns out the number of people going into radiology just continues to increase. So number one, regardless of what you may hear many years ago, there is always going to be a radiologist. In fact, there was a need for radiologists. One of the companies that I was affiliated with a couple of years ago, if you're a radiologist, we would start you off at over $500,000 a year, believe it or not. So that just tells you that the demand oftentimes determines your pay. And so if that's any indication, there's a shortage of radiologists, and the market forces are saying that if you get into radiology right now, you don't really have to worry too much about future compensation because there's such a shortage of radiologists. But when it comes, so number one, I want to dispel this incorrect notion that the field of radiology will be obsolete, and that's not the case. It just continues to grow and grow and grow. Regarding artificial intelligence, it's been used in all walks of life. I think if you have an iPhone, you've been using artificial intelligence, you don't really realize it. It's called Siri. If you've ever started to plan a trip and you're looking at options on your computer, all of a sudden your email, you may be getting spam on Facebook or something. You may be getting spam for the area that you want to visit. That's all part of artificial intelligence. It's been part of our lives for a while. And when it comes to radiology, it's been used for a variety of potential clinical applications. And one of those is cancer detection. And the thing about radiology is that artificial intelligence can be used to tell you if something's normal or abnormal. But if you want to say exactly what type of disease it is based on the AI algorithm, then we just haven't gotten there yet. So what I wanted to do was is just share a couple of slides that I have.
Absolutely.
Regarding, I think this is actually from one of the talks that I recently gave on artificial intelligence. So Ramu, just let me know when you get the slide.
I got it.
Okay.
Okay.
So what this slide is depicting is the Gartner hype curve. So Gartner is a well-known consulting firm. I think they're centered in the United States. And what they do is they track technology and they track trends of technology. So anytime that you have a new technology and there's some promise to it, on the y-axis here, we can see that it maps out the expectations. So you can see the higher the curve goes, those are higher expectations. And on the x-axis, there's this innovation trigger. There's this peak of inflated expectations and a trough of disillusionment. So this is the normal, if you will, life cycle of any technology. So it starts off with this innovation trigger. You have a very rapid slope and ascent. And this is important for any type of technology, because in order for a technology to grow, you need private equity funding, you need venture capital support. So in a way, this is what Gartner curves the hype curve. So you have to generate a lot of hope and promise that your technology is one day going to, if you will, save the world. But then what happens, you sort of reach this peak of inflated expectations, and then you have this rapid fall off. And then eventually you get into this, what we refer to as a trough of disillusionment. And eventually there's a little bit of hope, because at some point, a lot of these technologies are eventually going to be useful, but they may not have the same impact that one would have anticipated early on in that life cycle. So when it comes to artificial intelligence, two of the main components of AI are deep learning and machine learning. So this was the Gartner hype curve back in 2017. And then when you look at where deep learning and machine learning are, for better or for worse, is right at the peak of inflated expectations. So this is when a lot of those comments came out and said, we don't need radiologists, they're going to be obsolete, so on and so forth. Well, that was in 2017, and this was the talk I just gave just a couple of weeks ago in India at AIIMS, the All India Institute of Medical Sciences, and this was the Gartner hype curve for 2022, so just last year. And you can see deep learning all of a sudden went to the top of the curve and it went all the way down. So right now, deep learning is in the trough of disillusionment, and eventually, I think it will plateau out. And there will be some tangible applications for this. But to suggest that artificial intelligence is going to save the world, it's just not going to happen. And similarly, if I go back to the curve before, there was machine learning. Well, all of a sudden, machine learning is not even on this curve. I don't even see it. So I don't know what happened to poor machine learning. One of the challenges is that when artificial intelligence when these companies are created, and they want to introduce this in our clinical environment, it has to get FDA approval. Now, the FDA approval just means that this technology is safe. So if artificial intelligence is trying to replace a radiologist, it's not going to harm physically a radiologist. It's going to say, hey, we want to see whether this algorithm is equivalent. So what the companies have to do is demonstrate some level of equivalency in their testing to radiologists. So the way the companies do this is they go to the FDA, they say, well, we're not going to physically harm a radiologist, but we do think that the diagnostic accuracy of our algorithm is similar to a radiologist. So in this particular case, this was a sensitivity of 92% and 89% for a specific algorithm to look for fractures involving the vertebral bodies. So let's just say you were involved in a trauma and you went to the emergency room, and, God forbid, they were worried about a fracture to your cervical spine. Well, this algorithm looked like it was going to work pretty well based on the data that was submitted to the FDA. But this paper was published now 2 years ago. And when they looked at the sensitivity, the real world sensitivity, well, it was only 55% in the real world compared to the promise of 92%. And then the positive predictive value was only 39%, which again, is much lower than any of these other diagnostic accuracies. So this is just one tangible example about why that hype curve is a little bit much lower now than it was before.
Yeah. So false negatives can be very, very big problem, Dr. Mukherji. Yeah. So, one of the complaints I have is Chat GPT. Now they're talking about Chat GPT, but what we did not ask right questions, the journalists and even the politicians did not ask what happened to the artificial intelligence could not able to predict the pandemic and the deaths. We 7 million people died. We did not tell us what is the progression, and he did not predict any kind of a give us anything. It's not still not there yet. Is a chat gpd is still a descriptive algorithm. It gives you a very good answers, but to give us a pure prediction of the pandemics like that, it is not there. That is a good best example, and he gave another example of the how many false positives and false negatives are there. That is a really absolutely wonderful. So what you think that yeah, I agree with you 100%. That's why I would suggest the doctors to learn more about our side of the story, the Silicon Valley story. And then if they learn a little bit about them, I think they could do very well. That's what I'm this channel. I started it. It is a truly an honor, sir. Is there anything that they wanted to talk about a little bit? Anything that you're interested in talking more about this? Anything in radiology you want to say is
Well, I think
happening?
there's so much in radiology. I think, radiology, I think, is the window to the future, but, radiology on its own is more emblematic of technology. And I think one of the things that we always have to always remember when it comes to taking care of patients, there's a lot of promise with science and technology, etc. But what I always worry about is that sometimes we have to remember and remind ourselves about the humanity when it comes to taking care of patients. So as we kind of move forward and we start integrating new treatment pathways that are really based on data and information and artificial intelligence and new technologies, we always have to remember to put the patient at the center of these decisions. And we run the risk of having decisions based on computer algorithms. We have the risk of decisions being made, as you said, within Silicon Valley, just based on the latest technology. But we have to realize technologies, some are going to be beneficial, but the majority are not. And moving forward, we always have to remember that the patient still needs to be the center of our focus. And our obligation as physicians is to always explain the rationale, why we're treating the patient and what the real outcomes are, and to make sure that we can provide accurate information. So as we move in the future, this decision is not based on historically a doctor telling a patient what to do, but really it's to make sure that we always remember that it's the humanity side, and these decisions are now made in collaboration with technology, with computers, with the doctor, with the patient and their families. And I think if we remember that, then I think it's going to bode for a very much better future than at times I feel where our field is going.
I'm going to talk with a woman tomorrow at the same time. It is about the patient advocacy and making the patient center the focus. But I want to ask you before we leave, what do you think of the presentation? Does it make any sense for you? The loss of symmetry, that it is so embedded in the nature, that gives you some kind of a direction, and you give us some kind of idea to the future residents, your medical residents.
Well, I give a talk on Da Vinci. In fact, I just gave one a couple of weeks ago in Aspen, and it was merely based on Leonardo da Vinci and the Search for the Soul. So I believe that you showed the Vitruvian Man there. So I was very impressed that you showed the Vitruvian Man. And I have also heard that attractiveness is based on symmetry. And so I'd heard that before, that one of the reasons Tom Brady apparently is very attractive to women, and Tom Cruise and others, because they have a very symmetric face. Now, I never really knew about that, but apparently studies have been done that have documented that. So, I have heard that before. So I think there is a lot of credence to that. And I've also heard about the symmetry in the universe. You have people that are exactly like you, and then somewhere in the universe there's someone that's the complete opposite of you. So I think when you have principles like that have stood the test of time, there has to be a lot of credulity based on those important concepts.
In my view, all radiologists are symmetric, and we all need them. Thank you so much. It's truly an honor to talk with you, sir. Thank you coming back again on my show. It is truly an honor.
Okay, thank you very much, Remy. Always happy to help, and hopefully we can do it again very soon.
Thank you.
All right, bye-bye.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.